Controversies involving health data mean many people, particularly those from marginalised or economically disadvantaged communities, are suspicious about sharing data about their health. While the advantages of improving access to this data for things like critical research and tracking diseases are clear, there is still a long way to go. In this next panel, chaired by Emma Thwaites, the ODI's Director of Corporate Affairs, we ask, what can we do to build trust in health data to improve health equity across the globe? Emma.
Thank you, Navdeep. And I'm delighted to welcome a great panel for this discussion. With us today, we have Georgia Richards, who is the founder of the Preventable Deaths Tracker. This is a platform that provides the first and only open database of coroner reports in the UK. And joining us from Nairobi is Farhana Alara Kaya. Farhana is the Chief Data Innovation Officer at the Aga Khan University. And in Madrid, Spain, is Teresa Garcia Coscolin, and Teresa is the Health System and Shaping Access Lead at Pharma International Roche. Welcome to you all, and thanks for joining us. So I'm going to start off with a positive question, in a positive vein. And I'd like to hear from all of you, if you wouldn't mind, what you see as the most promising opportunities for the greater sharing of health data. And this gives an opportunity for you all to, I guess, reference your own work, your own projects. I'm going to come to you first, Georgia, and maybe you could tell us a little bit more about the Preventable Deaths Tracker as part of that.
Yeah, certainly. So I'm Georgia Richards, health research scientist and epidemiologist at the University of Oxford. So I come from the academic lens here. But I think the most promising thing around how I was actually able to establish the Preventable Deaths Tracker is that we have open data mixed with the ability to use open source software and have that ability to work with interdisciplinary teams. So I come at it from a health angle, but I'm working with coroners, lawyers, people in the open justice world, as well as computer scientists, data scientists. So it's that sort of interdisciplinary approach is how we were able to make use of open data and turn it from PDF documents sitting on a government website into an accessible, usable database that we can use for real-time analytics to have impact on preventing future or preventing similar deaths and bringing together all that skill set. So I think the positive side of this is that working together with different skill sets and making use of open data and open source software.
So Georgia, you're an epidemiologist by background. I wonder, from an epidemiology point of view, being able to track those coroner's reports and the patterns and the things that you see in that data, how that can actually help to improve healthcare, in what ways that is useful?
Sure. So coroner report holds different data. So usually in healthcare, we're used to looking at electronic healthcare records, or we can go to the ONS and look at, say, mortality figures and how many people died from a particular cause of death. What coronial information provides us is a more nuanced insight into the circumstances that led to death. And that's really where we can start to learn lessons for preventing death. So it's having that more nuanced data. It's the mix of quantitative information on, say, cause of death with the qualitative information on the circumstances and the issues and the learnings and the concerns that coroners had that led to this report being written.
So the more data sets from other kinds of data sets that you can pull together with that information, the better a picture, the more detailed a picture you actually are able to form.
Exactly. So we've moved the data from, it was PDFs online, one-star data, and then we've moved that to being a structured database where you can actually analyze that in either a CSV or an Excel type database. But it really needs to get it to that next stage of having, being able to draw lots more insights and learnings. We need to connect that data to other sources and link that database to be able to draw further insights.
Now, this issue of linking different types of data together, I know, is of a particular concern and interest to Farhana. So Farhana, I'm going to come to you next. Same question. What are the most promising opportunities for the greater sharing of health data? Again, when we spoke a short while ago about this topic, you also talked about the importance of identifying additional data sets to the health data sets and then being able to link all of that together. Could you say a little bit more about that, please?
Absolutely. So I'm actually in Rwanda right now, and I am at a Data Science Africa Health Conference, and this was actually our key discussion point this morning. I actually come from private sector. I've only been in academia for 2 years, and in private sector, I have firsthand seen the competitive advantage that private sector organizations have in the ability to combine data with other sources. With respect to, sharing healthcare data, I speak as a female in terms of, that there's a lot of gender bias. There's significant bias in healthcare data when it comes to gender, especially in the domain of, for example, medical research. We all know, as women on this panel, that if men had to give birth or experience menstrual cramps every month, there would definitely be different work policies and drugs on the market. The lack of gender diversity is very impactful, especially when it comes to gender-specific health issues, either being overlooked or not adequately understood. And so, one of the things we've done within our team at the Aga Khan University is we've actually built a very large repository of anonymized healthcare records from across Kenya, and where we have equal representation based on the population with male and female. And just with that data, now there is 14 years of history, we've been able to illustrate that women are 56% more likely to report adverse reactions to medications than men. And of those 56%, 59% were more likely to be hospitalized due to adverse drug reactions. So that's just looking at data as is. When I used to work for IBM, one of the things that we had built in terms of a software offering was the ability to take data out of an electronic medical record. And similar to Georgia, we used to combine that data with social and mental health determinants. And so what this provided you with now is a very holistic view of the patient. And so when people used this software, they were able to provide proactive preventative care protocols or mechanisms based on that holistic view. And this became really impactful, especially for vulnerable populations, such as the elder or those coming from marginalized communities.
And this is really interesting. So just picking up on that notion of social and the mental health determinants that go alongside the physical health determinants. I wonder what are the particular challenges that you've faced in your research and your work in countries in Africa, particularly, whether there are different challenges there to perhaps challenges that we might face in other continents or indeed in the West per se.
So I think one of the biggest challenges, on the continent of Africa is a lot of this data is not digital, right? I happen to be lucky to work in a university that has a hospital associated with it. And so we've had electronic medical records for quite some time. The software platform that I was talking about was primarily deployed in high-income countries where you do have this digital information. The part about it is you want to make it easy in terms of being able to bring that information together. And so, we primarily worked with a lot of public health type of organizations where from a, Minister of Health or the Ministry of Health, you were able to bring these various data elements together. And so this would then enable you to make a better decision because you had a more holistic view of the patient.
That's really interesting. What you alluded to there was this the notion that you need strong leadership in that data stewardship piece. I'm going to come to Teresa now. Teresa representing obviously a global organisation in Roche, an organisation that has a network of country affiliates around the globe. And I wonder whether, again, the same question, I'd like to see from you what you feel are the most promising opportunities from the greater sharing of health data, but also perhaps picking up on this topic of the importance of leadership in data stewardship and how you might see different effects in different nations as a result of the variability around that leadership.
Yeah, sure. Happy to elaborate on that. And thank you for having me. I think that the opportunity that I would like to highlight is the opportunity to provide better care. I was listening to the session earlier this morning, and I think Rebecca Disler mentioned about what is actually the volume of data that's coming from the healthcare sector. And it's 30% these days, and it's expected to go up to 36% by 2025. So it really means something in terms of the volume of data that is expected. And let me pause a little bit and explain why I thought about selecting better care. Because at the end of the day, it will have a really positive impact within the patients in terms of having faster access to treatment and also access to what we call much more personalized treatment, targeted therapies. And here there is a particular example that was funded by the European Commission, where they created a consortium in order to consolidate data coming from different sources to better understand rare diseases in kidney in particular. One of the outcomes of that project is that at the end of the day, 10% of the patients that initially were diagnosed as not suitable for treatment were able to be resuitable to another treatment. So it really means that adding that data could help to have much more informed decisions. And this goes back to the point that was made earlier in terms of the physicians will have much more easier access to the relevant information, and therefore they will be able to make much more informed decisions. But I also want to bring the point to a healthcare system perspective. And here, the better care also means involving other stakeholders as the regulators and the payers. And for the regulators, if we are able to provide insights coming from high quality data, it means that they will have a better understanding of what is the safety and the efficacy in the long term. And actually, the new data could help to solve some of the concerns when there is kind of a limited representation on the patients with some clinical trials. And I mentioned also the payers, because what we know is that if we are able to provide much more tailored interventions to the patients, at the end of the day, we should be able to shift from a cost perception to a value perception. And going back to your second part of the question on what we have seen working with some countries, we have a particular case working actually supporting with the Open Data Institute on a partnership working on Slovenia. And in this particular country, it was really, really important to make sure that they wanted to move into the implementation of the digital health strategy. And it was really, really critical to hear what was the value perception across all the different stakeholders. Because what we have seen across the globe is that the system readiness across all the affiliates is really different when we are discussing about trying to go into data-enabled healthcare systems.
You mentioned there some very particular, or a particular example of a country showing leadership in this domain. Do you feel, from your perspective, that we have knowledge transfer mechanisms that allow these learnings to be shared sufficiently broadly around the world? Because I think what I observe is pockets of expertise and pockets of best practice emerging, but those learnings are not necessarily always widely shared. I just wonder if you have any reflections on that and what you think the mechanisms might be for making sure that health professionals, indeed everyone involved in the health ecosystem around the world, has access to information and best practices.
Yeah, that's a good question. And for instance, here in this particular activity, we wanted to make sure that learning is coming from other countries. And in this particular case, we decided to showcase the example from Finland can help to inform the decision. And obviously, we also have to consider from a European perspective that we will have the framework on the European health data space that hopefully will also help to some extent with the learnings that you mentioned before.
Thank you. So I'm going to slightly change the optics on the topic now for a minute and look at this from the patient's point of view. So obviously in the West, certainly there's been a good deal of suspicion amongst the general population around sharing health records. Here in the UK, of course, we've had debacles, so it's a long time ago now, about 10 years ago, around the care.data initiative, and that certainly hasn't helped matters. So in terms of getting people comfortable with the notion of sharing data about them in ways that are safe and ethical. I wonder, Farhana, if you wouldn't mind reflecting on whether the issues are, as you see them, whether the issues are the same or different in countries in Africa.
I would actually say that, the issues are very similar. And in fact, there's probably less trust in African countries because not only are there stories of corruption, but there are lots of stories in terms of how data has been leveraged for harm and not for good. However, until very recently, you haven't had much that protects the citizen in terms of legislation. And so many countries are just now introducing any form of data protection regulations, any form of privacy regulations, et cetera. There have been, I'm going to call it policies in the past. However, they haven't had much teeth. But I can specifically speak for Kenya, with the Office of the Data Protection Commissioner, as well as the Kenyan data protection law that came into play in 2019. There is a lot more legislation around this. One of the things in terms of, sharing data is this concept, where you get to leverage artificial intelligence or generative AI. And so one of the things that we've been doing within our team at the Aga Khan University is we've been working on something called synthetic data. And so what synthetic data is, you generate using machine learning, using artificial intelligence, a representation of the data. However, you are able to protect privacy. So it's not the real data, and it's not just data that's anonymized or you have de-identified. So, what we've been doing is we've been working with community health data. And so we've generated a synthetic version of this data. And in terms of quality, we know after running a bunch of additional algorithms that 96% of it from a quality perspective matches. So that means it's very representative. But from a privacy perspective, it has 3 nines of privacy. What that means is it's 99.9% able to anonymize, not just anonymous, but de-identify the patient or the community health participants' identification. And so therefore, the probability of being able to re-engineer and understand where this data came from is like slim to none. Now, I don't want to leave you with the impression that this is a silver bullet, because generating synthetic data, I just mentioned like a bunch of machine learning, a bunch of artificial intelligence. It's not a trivial task, but it is potentially a way that as we move forward and as costs come down and as that knowledge starts to increase, that it could be a way of sharing data.
I think synthetic data is really exciting in terms of the potential benefits that it offers. Teresa, I don't know whether you have any thoughts on the application and use of synthetic data. Maybe that's part one to my next question. Part two is around your observations in terms of different attitudes to the opportunities and the risks of sharing health data around the world. I'm thinking here particularly about patient data, about data that relates to individuals. So any thoughts on synthetic data, and then what you're noticing in your experience of health data around the world and patient attitudes to the sharing of that data?
Yeah, thank you. I will start with the second part of the question, because I think that what I'm more than happy to share, as I was saying before, is that what we have seen in terms of the level of readiness for sharing data. And here I will consider not only the patient perspective, but also the relevance of the other stakeholders, as I was saying before, from a regulator perspective, from a payer perspective as well. And from what we have seen, I would like to highlight 2 main factors to really make sure that there is comfort in sharing the data across the different stakeholders. The first one is about building trust, as Farhana already said. So how can we approach to establish data only for public good? And the second one, and this is for my personal opinion very important, is that how we can make sure that there is a good understanding of the value of data sharing across all the different stakeholders. And here I would like to call out a particular project that we just commissioned with Frontiers Economics, will be published really soon, when we wanted to put numbers behind what is the value of data flows, right? What is the value of data sharing across organizations, across countries, from a supranational perspective, to really make sure that there is an understanding on what is the impact of those data flows when we refer to investment in healthcare. What is the impact of data flows when we refer even to trying to cost savings when we conduct some clinical trials? What is the impact of data flows on having access to personalized healthcare? So this was a very good example of trying to put some numbers of things that really matters to the stakeholders. At the end of the day, they really need to make sure that there is this ecosystem readiness. And also, going back to your question on what I have been observed, coming from this report, there was the opportunity to consider that in some of the jurisdictions, the applications of GDPR is not the same, and there is not the same level of understanding. And therefore, this has a negative impact when we are trying to share data. And the other challenge that we have observed, this is coming from the technical, from the infrastructure perspective, meaning that if there are not the necessary IT investment and interoperability on the data, therefore it's really, really tricky that we can move really into the value of data or data sharing.
Excellent, thank you. I mean, I think this issue of trying to prove the value of data and of data flowing around an ecosystem is a real challenge, because actually some of those benefits are not that easy to observe either in a clinical or a different kinds of settings. I guess coming to you, Georgia, this is one of the reasons why, if I dare say, you're having to bootstrap the project that you're currently working on here in the UK. But I know that it's different in Australia. So you have been able to, or those that are working on this project in Australia have been able to prove the importance of it. Could you say a little bit about why you think that's the case, and what we might be able to do to change that here in the UK and in other nations who might want to set up a preventable deaths tracker?
Yes, certainly. So I'll just say what Australia has done. So Australia, since 2000, so 23 years ago, they set up a database of all data collated on inquests, so we could learn lessons from all inquests that were heard. And when I talk about this example, people in the UK say, oh, that could never happen here. And we talk about the population size differences. But Australia, like America, is a state-based system. So they were able to get all the different political parties in the different states to sit down together in the year 2000 and agree on a funding model where justice departments and health departments of those different states came together. And I do have to say, it's not just Australia, it's Australia and New Zealand. So this is a multi-country database of data from both Australia and New Zealand. So the barriers and the challenges I think we have here in the UK, so we don't have the challenges that Australia had in terms of the state-based system. We have one justice department and one health department that we need to get to sit down together and agree on this. But at the moment, no one wants to take responsibility for this. So the Ministry of Justice wants to give it to the Chief Coroner's Office, and the Chief Coroner's Office wants to give it to the Ministry of Justice, and then they've got the health department there, where most of these coroner reports are written to. So it's the lack of accountability and responsibility. And then what happens when we find things in the data? So what happens when we find issues in how these deaths occur, and who's responsible?
I think we may have lost our Zoom call, which is a great shame, because I had a whole raft of additional questions that I was going to ask our panel. We might try and get them back now, Dip.
Yeah.
I just wonder what your thoughts were on that.
I was actually thinking about the pandemic, and how much have we, that was something I wanted to ask, because the panel was around what have we learnt from the data a year on, and the different levels of sharing between governments and so on.
Because we did have a huge amount of opening up of data and sharing of data around the pandemic, particularly to track the emergence of the different variants at that time. And I think the feeling is that system that was created just hasn't been maintained.
Yeah.
And actually there was a really interesting comment earlier on today in the chat, which I noticed. There was an audience member who mentioned that actually in the context of the pandemic, AI's actually exacerbated the inequalities around the world and made vulnerable people more vulnerable. So I really wanted to ask the panel about that. It's a real shame. It doesn't look like we're going to be able to get them back. So I am going to, in their absence, I'm going to thank Georgia Richards from the Preventable Deaths Tracker, Farhana Alara Kaya, from the Aga Khan University, and Teresa Garcia Coscolin from Roche, for a really interesting panel.